But what about different causes and confusions? We talked a little bit about Gazzaniga's work. There's also medical conditions that could result in or be confused with ADHD. And as good evaluators, it's good to know all of these, under some circumstances, that is. So you want to make sure you have history of head injury, because that could lead to inattention. You also want to know about any encephalopathies, which aren't necessarily always going to happen, but they could result in attention problems that isn't necessarily ADHD, but due to brain damage. You also want to know about hypothyroidism. We're talking about other medical causes, and lead exposure, and lastly, fetal alcohol syndrome. Now, of course, we've all heard about the genetics and how if a parent has ADHD, their children are 50% likely to have ADHD, siblings at 35%. Other research is showing that there's genetic predispositions for developing ADHD, specifically in these areas. And that there's risk factors for developing ADHD, specifically if there's any pregnancy or complications or birth complications. And you can read through that list as well. Anytime I hear an inmate that I've talked to, I'm doing a clinical interview, say, yes, mom was using crack cocaine, yes, mom was drinking, an immediate follow-up question was, when were you diagnosed with ADHD? And in my experience, about 75% of them say, oh, 5 or 6. Or, I was never diagnosed, but my teacher always wanted me to get diagnosed, but I was always, the class clown, I was bouncing off the walls, etc., etc. The reason that I ask it like that is because I like to presume things, but also because if things happen in utero, we can predict that there might have been some microscarring that then resulted in the symptoms of ADHD, if not the full diagnosis, as a child was. But what about other causes? What about abuse, trauma, neglect? What about attachment? Well, we talked in the last class about how abuse affects the HPA axis, the hypothalamus pituitary adrenal axis, by causing a surge of cortisol, the stress hormone. And can you imagine being exposed to that every day or on a random interval as a child and never knowing when the next slap is going to come from and always being hypervigilant? That physically changes your brain. But in the same way, studies have been shown that children of extreme neglect versus children with normal brain show a lot more atrophying of the brain. And so many of the symptoms that we might be seeing may be due to abuse and trauma or neglect. So it's really, really important to find out a good history. Is the person in front of you someone that came from an enriched childhood where they weren't neglected, where they had all the food and water and clothing and shelter that they needed? Or is it someone who is fighting for their next meal and looking out of trash cans to eat? And you might actually diagnose them with ADHD, but you can also know in there where you think the causes are. Because, right now, because the symptoms are there, if they meet the criteria, the treatment is still the same. They may still be helped by medication. They'll definitely still be helped by behavioral modification and structure. Theoretically, they're now hardwired, and they're going to have struggles throughout their life. But as good clinicians, we can, as evaluators, identify, and as treatment clinicians, actually help build in behavioral plans, maybe medication, certainly a structured environment to help them. But what about attachment? I always like to throw this in here. There's a lot of good work being done talking about attachment. This comes out of the work of Ainsworth. It is theoretical, however, it's been the focus of many, many studies. And we're talking about secure attachment. That's what we all aim for: healthy, loving environment with a primary care physician, we know, primary care provider, someone to take care of you and build your neural networks. But then there's the insecure attachment. That's the other half. And children with insecure attachment can kind of be grouped into 3 different types. One type is the ambivalent, where the child goes to the caregiver for support while simultaneously rejecting them. Go away, go away, go away, come here, come here, come here. And that comes from a parent who's fairly inconsistent with their parenting or provider that had an inconsistent household for them. There's the avoidant, where the child rejects the caregiver outright. And then there's the disorganized, where the child doesn't really have a strategy for getting their needs met. Now, why is this important in this type of class? Well, executive functioning. Early healthy attachment must be made for developing executive functioning, and both children who have insecure attachment and children with ADHD have executive function deficits. Also, the HPA axis that we just talked about. It's atypical reactivity to a system of stressors, and the severe attachment are also associated with atypical reactivity. Someone who doesn't have secure attachment doesn't know how to react. Finally, some children with ADHD show atypical reactivity. So this is all out of Creighton's work, if you want to look up that information. Attachment with regard to the orbitofrontal cortex, that's right there. It's critical that emotional regulation and decision making be made for processing of rewards. Well, anxious attachment inhibits the development of the orbitofrontal cortex. Anxious attachment may also result in chronic impulsivity, emotional lability, unpredictable behavior. What does that sound like? ADHD, right? And studies show that children with ADHD have deficits in this area of their brain. Yes, sir? And what this kind of boils down to is that symptoms of attachment deficits mirror symptoms of ADHD. Now, that doesn't mean that they're mutually exclusive. Children with attachment problems may be diagnosed with ADHD. And the treatment might be the same, in the same way. But it's something to pay attention to and get a really, really good background read. You know, is it physiological? Is it something they were born with? Is it something they developed? I don't know. Is it all 3? Yeah, and there's a lot of overlaps. You know, children who, or people with attention deficit disorder are more likely to take risks, get on that motorcycle without the helmet, dive off the perfectly good airplane, bungee jump, do thrill-seeking behaviors, sure. And they're more likely to have traumatic brain injuries. So, is it the ADHD, is it traumatic brain injury, is it attachment? It kind of all goes together at this point. Since the criteria overlap, the treatment is the same. But it is kind of interesting, and it's good for us as evaluators to tease this stuff out.